Perfect.
Great.
So if we go like, okay, neurological exam, what would people normally do for a neurological exam? Come and have a lie down.
Well, I've been forced to do it a bit more. We've been doing some work with doctors with insurance cases. And I went through my first neurological exam for years and years and years, and then I've started doing it a bit more. Biceps, triceps, I made it up, well, you know, C7, C6, C8.
Yeah. That's pretty much.
I'm very lazy.
I know, I think it's a string, isn't it? So generally, that's exactly what I would do. So,
Oh, up is down and down is up.
hey?
Pull up.
Look at me.
Oh. So if you're like me and you've got the really poor reflexes, sometimes it's quite hard to elicit on a patient. So it's worth practicing and doing it on as many people as you can. Just because they haven't got a reflex doesn't mean that you have to freak out. Like if they've got good strength, like 5 out of 5, but an absent reflex, they might just have crappy reflexes. But if
How
they've
hard do you go hunting for, you know, because that the
got,
stuff that we're looking at now, like doing like these kinds of things, or getting them to wiggle their toes, or
I compare it, if I can't get it on both sides and it's a unilateral thing, then I go, okay, and they're generally like that, I'm less worried. If I can't find a reflex and I think they're weak, I'll hunt a bit more. And if I still can't find it, and they've got, something that relates to that. But yeah, essentially you're looking at, and you might just get the muscle belly flip. You might just get that with someone, or you might get someone that actually moves. So yeah, you want that. Triceps I always find a little bit tricky, and you'll find at one side you're better at doing it than the other side because you're doing it with a different hand, or you're trying to do it like this. But I also sort of hunt around there a little bit because sometimes I find it's a bit more lateral than it is sort of medial. So I do that one. I sometimes do this one on brachioradialis because that could be more C6. And then I know people that do hip flexor, knee, hamstrings, the whole shebang. But I don't know. If I'm just doing a screen, I'm going like, okay, she's got that.
I take it as we're not the ones doing surgery, we just need to
No.
know how severe the neurosurgery
And sometimes people will do it to try and really identify, well, if it's the medial hamstrings, it's more L5, L4-5, or if it's the lateral, it's more S1, and I don't know if that really matters for me.
No,
I don't know.
we're not.
So yeah, then obviously I do that one, and I sometimes do the plantar one as well.
Why? What does that do?
Oh, I'm just sometimes get a better, it's the same thing, S1
Yeah.
to
Yeah.
reflex, but I sometimes just roll through that and see. Sometimes I don't get the ankle one at all. For Babinski and clonus, so for clonus you're taking into that stretch, and then you're there, and then you're just doing that sharp. So I go, I'm just going to stretch your ankle, and then I go, I'm just going to do that quickly. And I'm looking for,
And positives.
Yeah.
Back.
Beats.
and you're looking for so many beats, like if you look in the literature, you're probably looking for more than 2, because some people will do that. I think it's a good idea to have the knee bent, because sometimes you get people, if it's not the neck, that have, sort of sciatic type of sensitivity, and that's uncomfortable, and then you do it really quickly, they don't like it. And then obviously your Babinski is coming out the lateral border and across the foot, and what you're trying to find without making people have that real flexor withdrawal is that there's that subtle clawing of the feet. Don't always get it. What is a positive is if they do that, because they're going to do that for a kid. So that's kind of like reflexes.
So do you do knee reflex for neck?
If I'm concerned about that, because you can get a myelopathy, so I had a patient that had a myelopathy and he got foot drop that came on after neck pain.
Okay.
And ended up having to have an emergency surgery. It wasn't my patient at that point, but I saw him afterwards, and he was a doctor and said, yeah, it's really weird, I got neck pain and arm pain, and then a few days later my foot started slapping on the floor. So if you have any levels of concern, and like that should take you,
Yeah.
like,
Well, if you're going to do Babinski and clonus,
and like if someone walks into your treatment room like this, well, gate's a bit dodgy, And I might just go, oh, can you just walk on your toes? Can you walk on your heels? And I've just done L5 and S1.
Yeah.
You know.
So you use your thumb for Babinski as
You
opposed
can.
to the-
I sometimes find that's a bit too tickly,
Yeah.
so I use my thumb.
So it's not really a quick.
Can be, but you're trying to create that. It's that sort of speed. If you sort of start jabbing in and do, you create a flexible jaw, which doesn't tell you anything. And I
Yeah.
guess what you're looking
So
for.
what is it? Positive is going back.
Positive would flare your
Yeah,
toes,
the toes
whereas
back.
usual response. is
Whereas
up.
this
And,
one.
and what, just remind me, what does that mean again then?
It means that
Upper
it's
motor.
probably an upper motor.
Something
Neuron
cooking
issue.
in the brain.
Yeah, something more central as opposed to peripheral.
Yeah.
So it's a
I've done
way
it
of
for-
just clearing that.
Yeah.
So I would go through reflexes like that. I would go through muscle testing. So I've just said like, I might do, can you walk on your toes, can you walk on your heels, and that might be it for the lower limb.
Yeah.
If I'm focusing more in on the upper limb, I do like a bit of a hybrid. I generally don't do, C1, C2, C3. I generally start at C4. And if you look at the Asia thing, they start lower, C5, I think, for whatever reason. So I would go, can you elevate the shoulder, keep it up like that, don't let me pull it down. Yeah, that's good. And I would go, keep your arm there, don't let me push it in. And then this is the stuff that
So
starts
you're
to...
just pushing on the elbow there,
I don't want to...
resisting
Yeah,
abduction.
yeah, exactly. And obviously you've got to go over your shoulder issues and this, that and the other because that will affect it. This is where you're starting to go, I'm more interested, or I've got my alert on is around here. So can you hold that? Yes, you can. Can you stop me pushing? Hang on, so I'm going to push towards you, don't let me bend your arm. So, these are the ones that you're going to start finding stuff on. I do this as well.
So what is it, the brake and the, do you try to...
So you can grade it out of against gravity and then against resistance and against maximal resistance.
Yeah.
I just go, can I go until they can't push me anymore?
Yeah.
And that's pretty strong.
Yeah.
So I do, so you've got C5, 6, C7, but this is also C6 here. So keep your wrist pulled back, don't let me push it down. So I had a guy that couldn't hold me up like that, but he was actually pretty good with that. And so if I just did that, I wouldn't have picked it.
So C6 is wrist extension.
Yeah. And then you've got finger flexion, and then don't let me extend, and then hold your fingers out like that. That's C8, T1, thumb back. So I do a bit of a hybrid to try and just cover all that. And if there's anything obvious, I might hunt it a bit more.
So
Yeah.
thumb and little finger, you're doing...
I'll show you on the thing. I think that's C8 or T1. That's
Yeah.
T1.
That's true.
They don't do that. They do little finger abduction. Don't let me push it in.
Okay.
So if we think about, what we talked about, C5, 6, C6, 7, there are common areas. Radiculopathy is C6, C7 nerve roots. They're the ones that I'm really going to start hunting. For sensation, so light touch and pinprick, I would be C5 on the elbow, C6 on the phalanx of the thumb, same for C7 and C8, T1. And I compare that to that side and I'll do the same thing with the pinprick. Yeah, and
So
it just,
pinprick,
pinprick, I have
What's
cocktail
that?
sticks.
pardon?
I have cocktail sticks.
Okay.
Have you got cocktail sticks? So I've got little, you can do it with that.
Like the wooden ones?
Yeah. Yeah, so I'll do the same thing. Does that feel the same as
Yeah.
that? Because you're assessing different
Yeah.
sensory fibres.
Mm.
And that works well. I've picked up a few that I probably wouldn't have picked up is like, does that feel the same as that and all that sort of stuff. It's too much, too long.
Mm.
So this is just key points. Yeah. Do you want to have a go at that on each other?
Yeah.
Yeah.
I'll show you
Is that
this.
similar to what you?
Yeah. Do you always do it in lying down? Because I always do it
You
in
can do it in sitting.
Doesn't matter.
Yeah, some people you might not be able to assess lying down, so you've got to be able to adapt. I guess that's the.
Where are you putting yours?
I was
Where's
gonna
my-
go.
this
I'll
side?
put mine on my bag and then it's even.
I'm very reflective. I had to do this through my fingers yesterday at MLCOA. There was no thing there, no hammer.
I was trying to mind
She was
it.
just going through skin.
So there you go. There's your sensory key points, which is
Okay.
part of the Asia.
Okay.
Okay, could you send that to us?
I'll send that over. Yeah.
Do you want to be break ready?
There you go. It's the international standards for neurological classification for spinal cord injury. That's their worksheet that they would go through for motor, and they're all the different key points.
One of those assessments done.
So I haven't ever done
Oh,
brachioradius. That's
it's quite
really
easy.
effective, isn't it? And so what are we saying for brachioradius?
C6.
C6.
Which would be really common.
That's the.
So
These
Oh,
are
yes.
those
Five,
sort of
six.
key
Five,
points. I'll
six.
send this over.
and one
And they've got the
tricep.
same for like
Yeah.
motor exam.
So that's lower.
7, 8,
And then six.
C6.
But six is so common.
You've got the essential
Yeah,
key
okay.
points.
And then what are
You know.
And it just
Well,
keeps
that's
it
it.
really,
Yeah.
really simple.
sometimes they seem to
That's the same for the lower.
MLCOA, they want you to
Okay,
do
cool.
is it this
And then you can be confident
or something?
Yeah.
with what you're doing.
Yeah, I don't know. They make
Yeah.
they kind of
Yeah.
the orthopedic way.
So sometimes the orthopedic surgeons up the road want us to do, I think it's like supinator or something in the.
That's C8, isn't it? I think. So we do telehealth
Oh, yeah.
insurance claims,
Yeah.
but they're all FIFO
Yeah.
orthopedic surgeons, so
Yeah.
we are their hands. So they tell us, we sit there from subjective,
Yeah.
and then they tell us what they want to measure, and we measure and tell them what the range is. And we,
So the supinator's up here, so I wonder what they mean.
they don't know what they mean half the time themselves. You do these things that they do big payouts, and they're like, that's the practice assessment.
Mm. So I would follow that. Like maybe let's do
I tend
that.
to my preference tend to be mine.
And then, so you said knee bent for this one.
Yeah, I guess with this,
Similar
it's
to
sort
what
of,
you did.
it wants to be like really kind of, it should take you like 2 minutes.
Yeah.
And it's only if
And
you're
the
really
calcium.
hunting, it's only if you go like, oh, hang on a minute, I really need to check that. Most of the time that's not an issue, now I can look at what I really want to look at.
Yeah, okay.
I'm always
Yeah, okay.
So
Yeah, so it's all done, and
Yeah,
then sensor.
sensory. So put both hands there, so,
Outside C5.
So I would practice this because like with anything that we do in physio, if you sort of like, I remember when I first did my masters, I'd go in and I'd go, is it low back, is it SIJ, is it the hip, and I'd check everything and I'd come out going, I still don't know if it's low back, SIJ or hip. So you want to kind of get something out of it, and if you're not getting anything out of it where you can go yes, no, or I'm suspicious of that, you probably,
it's not,
it's not worth doing.
no.
Do it, yeah.
Yeah.
So that's subjective, you've got to have a reason, that answer's got to tell you something.
I
So
get so
try it
other
later.
neural tension tests, like all the different ones.
Yeah.
I mean, it seems from research that now you could possibly just do the median nerve
Yeah, you
to get just whether you need to then
and
go
different people
further,
would
is that
say,
right?
yeah, I guess
Or do you
From-
use it a lot?
I want to know if that pain that they're feeling in their elbow is radial nerve sensitivity,
Yeah.
so then I'll load it and I'll palpate it. But yeah, do you need to do that to go, they've got a radiculopathy? Probably not.
Yeah.
Because if I look on tense, but if I look away, I can go back.
How is it? Are you getting different in
Yeah.
different positions?
I like
And then T1.
triceps in
So
super
C5.
lane.
Yeah,
Yeah.
okay.
Yeah, so
Yeah,
Five,
exactly,
six,
exactly.
7.
What, and do it across?
Yeah.
No, I
Do
do,
that.
yeah. And that's why one way you're
So
going to
it's just
feel
like
a
round
bit
the bottom,
cack-handed, and there you go.
Okay.
And listen, like all this, like, you know, 6 times the fatigue of a reflex. If it's there, it's just move on. Boom, reflex, great. Let's do the next bit. You can start worrying about all that other stuff if you need to. This is like a string.
Yeah.
So I know people that will do 6, and they go, oh, the reflex is getting less and less and less.
Oh my god.
I don't know if that's useful.
And have they got our appointments?
No, exactly. I haven't even got to looking at the neck.
No.
What about the whole, that,
Yeah.
that was the other thing that they were
That
saying
might
in
work
that
in
other,
shoes.
no, but about not putting the Achilles on stretch when you're going to do an Achilles. That was in that hip lock.
So you've got to put it on a
Yeah.
little bit of stretch because you're
You're
stimulating
Yeah.
the Golgi tendon organ to produce a contraction.
Yeah.
So if it's not on stretch at all, hitting it with the hammer is probably not going to stimulate that stretch response. However, if you put it on a lot of stretch and give it a whack, it's not going to work either. So you've got to find that sweet spot.
Okay, yeah. So you're putting on a little bit, but not in.
Yeah.
Right, yeah, let me do you quickly.
Yeah.
Got my shoe off.
Well, probably.
Oh, just take your long sleeve off.
And I'll just show you what Hoffmann's is in a minute.
Oh yeah. Well, we can practice this ourselves.
Yeah, okay. Alright.
Yeah, don't hit me on my.
I think it's like I would get into the habit of being able to go right the way through.
Yeah,
If
we
you
can
don't
practice this, that's
If
fine.
you don't get a reflex on someone but they've got 5 out of 5 muscle strength testing the muscle, it's less concerning. They might just not be a good reflex. Hoffmann's is where, if I come on this side, is where you get it's usually the middle finger and you flick this distal phalanx, and what you would get as a positive sign is you'd get this gripping of the thumb and the index finger. So that's a Hoffmann's test.
What's that testing?
It's the same as big
Upper motor neuron.
upper motor
So
neuron.
this would go out there.
So you would get, you can see it on YouTube, you'd get this sort of happening as a reflex response to
Thank God I didn't do it.
to that stimulation. You're alright, you're saying. But that's kind of, you know, and again with all of these things, there's nothing that is, like if it's that, then it's upper motor neuron for sure. You know, they're all, they
Yeah, it's
have
all
a,
going to be part of the picture.
and they all have a relative sensitivity.
But if you've got someone with a breast cancer history and they're a bit headachy and necky,
and this, that and the other, you
it
go,
would be
okay.
prudent to build up a caseload or you know, a case
a
for
good,
yeah.
yeah, a good screen overall. Okay, cool. As you're there, Annie,
Yes. Well done.
down is up and up is down.
Well,
No, up is
not.
up and
It's
down
not.
is down.
That one's that bed's the other one. I got one. These are the NRAF ones I could get. I got them imported and then they stopped sending them out to Australia.
Come and have a sit over the edge.
Yep.
So if we go, so that was a neurological exam. I think we're going into cervical range of movement from there. So you don't need me to go, can you look left, can you look right, and look left, look up, all that sort of stuff. Generally, with a common neck complaint, you're going to get pain in a regular pattern or an irregular pattern. Regular pattern is called regular because it's the most common, so that's where you're compressing a joint. Yeah. So if Annie says to me, when I turn to the right, I get pain on my right side. When I side bend to the right, I get pain on my right side. That's a regular pattern. If she goes, when I look to the right, and it's a compressive pattern as well. When I look to the right, I feel it on my left. When I side bend to the right, I feel it on my left. That's irregular and that's a stretch pattern. Yep. So, I would obviously look at all those ranges and see, you know, where you're restricted. So usually I reckon you look left as far as you can go, good, and you look right as far as you can go. Sometimes so a little bit more restricted to the right, and you sort of see that Annie, when she gets there, might side bend a bit to make more range, and so you're looking for those little common things with people. Then obviously I would get to look down, chin to the chest, as far as she can go. What does that feel like? Come back up. Side bend, and I try and keep her in that sort of frontal plane, side bend, and compare that. If I'm getting, it's regular pattern with all those things, I might combine them just to be sure. I usually leave extension to the last because it can be a bit more provocative. So if you just look up, well, first of all, I want to see how she does it. Yep. And again. And so I'm looking how much of a mastoid process goes back as well. So she's a bit more upper cervical in her approach. And I might go, again, you have to be careful. What about if I block you down here and I take you into lower cervical extension, and that might be a bit more uncomfortable. If it reproduces her pain, then that's kind of like all pointing to this compressive pattern. If you've got, I get people that can't look up without supporting their head because they're just not strong enough. So you just want to see how they do it, what they're avoiding, what have you. Yep. If I'm going to combine movements, I might go, okay, just look that way. Does that bring on your neck pain? Oh, if I do, yeah, that makes it worse. Yeah. So I'm taking those joints down as far as I can go. If she's got pain that's coming out around, referring into her arm or down her shoulder, then a test called Sperling's test is going to close that foraminal space down to its maximum, and if the nerve is irritated, it will probably reproduce those symptoms. So you would go end of range. I won't take you to end of range, but this is what you would do, end of range, and then the last bit is you can actually load it. However, if you go, that reproduces my arm pain, you probably don't need to do the other bits because you've already kind of, she's just more sensitised. Yeah, so that's Sperling.
So you would expect
reproduction of your referred symptoms.
Yeah.
Yep. If I'm looking,
or worsening, that they could still have them there, right?
They could have them there, but yeah, that really, I can really feel that down in my arm or in my shoulder or what have you.
And because that is compressing the nerve as it exits.
Yeah, so if you go back to that slide where we looked at closing down that foraminal space by extending or downsloping that joint as much as we can, that's a downslope on the right.
So it's like a combined
That's a
movement
downslope on the
with
right.
overpressure
That's a
and compression.
downslope on the right. That's as far downslope as we can go.
Yeah.
Now, if we're looking at upper cervical spine on its own, so generally upper cervical spine is extending and it's flexing. So that's upper cervical spine movement. So if you go, well, that's a bit limited, or that reproduces her pain. What I'm trying to do as well, I'm trying to keep the mandible fairly horizontal. So I'm going to guide the chin forward and I'm going to push down on the occiput to bring that out.
So you're pushing towards her chin?
Yeah.
Yeah.
Yeah. And then I'm going to draw a chin in and I'm going to lengthen back. You can combine movements a little bit by going, okay, stick the chin out. And then you can add in a little bit of sort of rotation to try and stir that up a little bit more. And if it's sensitized, it won't move much, but she won't like it and she'll tell you. And it's the same, draw your chin in. And then you can add in a little bit of that rotation. Because it doesn't rotate much, you're just really loading that capsule. Yeah, that's C01. Yeah.
And again, you're only doing this on a patient who has got some restricted movement from the first assessment, like if they've had full range of motion. Are you still going to do this?
Possibly, depends on where their pain is.
Yeah.
So if their pain's quite high up, I might do that.
Yeah.
Or if they've got a headache related to neck pain, I might do that. C12. C12 is I find that big spinous process of C2, which is the most palpable one down from the skull. I might then bring my hands out and just block that and don't let that move, and I might just turn the head.
Oh, is that how you assess that?
Well, there's lots of ways. This is one. This is a quick screening. You should get 13 to 15 degrees.
Oh, not more.
Not more, no. That's a confusing bit with this test. It's also an alar ligament test.
Yeah.
Because you're not allowing C2 to move at all in C3.
And if it keeps going,
Yeah,
there's no passive restriction.
So I'm just blocking the articular pillar. I'm not letting C2 rotate. I'm rotating C0 and 1 together on C2.
It's quite nice.
That can be a treatment as well.
Yeah.
A modified flexion rotation test, and I'll show you the actual flexion rotation test in a minute, is to go, right, if I get you to take your chin all the way down, all of those other vertebrae that do combinations of movement are kind of at their end of range. The only one that's going to sort of provide rotation now is C1, 2.
That's what we do.
Yeah.
That's
might
one of
just
our
go-
tests.
Yeah, I might just do that and have a look side to side what that's like. If that looks a bit restricted, I'll hunt a bit more and just to prove or disprove what I've got. Yeah. And then for the rest of them, if I'm looking for restrictions in the rest of them, I'll go into some motion palpation. Do you want to do that bit first, and then we'll look at the motion palpation? Just get a feel of it, and again, you can practice this later.
I like the C1 too.
Touch buttons.
So we did the rotation. We've done the rotation, and then so
You're right the first time. I had it all figured out.
Yeah, I'll put your hand on the back of her head, and you're guiding it forward. So you're trying. Remember the skull sort of like a rocking chair. So you're trying to guide it forward. Yeah. So for me, I would do it like this. I would go. Okay, I'm just going to guide the head forward, and I'll take her right out. Yeah, and that's probably where she wants to go. And then I'll draw the chin and go along through there. So that's that flexion extension.
hand presses down towards the chin.
Without flexing through that thoracic spine.
Yeah, so that's why. Yeah, that's true. But you'll still get C
Yeah, it was pulling strong.
0-1 movement, but you'll try not to get slump.
Yeah.
You'll still.
okay, yeah. So that translation
Yeah, so you'll
from the
get
front too.
So if you watch me, I would push your head.
So we're
forward,
looking
I'd say
for
something like
reproduction of
that,
your
sit your head
pain.
Yeah,
chin
and
on
how
the
much
shoulder,
movement there
and
is.
that
Yeah, and
is end of
then
range into extension. there. She's not got any more upper cervical spine
so
extension.
there's C2.
Yeah.
Sorry, in here.
Block that.
Yeah, under, so you want to guide her up through the
And then
man.
rotate, it should be about 13
Yeah,
degrees.
and you want to feel at the end of the movement.
Yeah.
Feels the same. I think I'll probably some.
Yeah, and if she slumps or she doesn't slump, you still should feel at the end of the movement. I'll do it on you. Shuffle along with it. So like for
Does it feel
instance,
like
I might go,
Yeah.
okay, just bring your chin out, and I would go,
Restricting
I
the
wanna feel
Yeah,
there.
it's not going
So
anywhere.
that is end of
And
range.
then,
Essentially,
and
if you
ironically, I
slump,
go, that's giving me a headache.
you still sort of got
That
you
is
in
familiar,
there.
but I don't
And
have
then
headaches.
So
we'll
I'm
do it
looking
all
for
with
end of
combined.
range. That
Yeah.
feeling won't go anymore.
So rotation, and then side flexion, extension, yeah,
Yeah.
Yeah.
and
The
then
So
C2.
it makes me feel very old.
Yeah, so this is, so remember, like, as we get older, we're going to get some joint changes in the cervical
yeah.
I
spine.
feel young, and then you start loading up my neck.
A lot of people won't like that anyway.
no.
So you can do that.
Compare that to the other side.
Actually,
So you're not really comparing movement there. You're just looking to reproduce.
So if
that
you're
pain.
going, does that reproduce your neck pain? Right rotation, yes. Right side flexion, yes. What about if I go that way? That's really painful. Okay. This looks like a down slope on that side.
Yeah, don't
Yeah,
need
so
to
I
be
go,
going.
I don't really like that.
Yeah, because a lot of people.
That's kind of alright, and then do the combined movements.
Yeah, that double chin.
Which one to the right?
Yeah.
Double chin?
Yeah.
Who's got double chin?
I like that thing. I like
Right.
that.
Yeah.
Like if you would assess
Oh, yeah.
active range.
Yeah.
Like the
Yeah.
other
And then-
side.
And so then you
And
just
you're
focus
gonna
on
use
treatment.
Yeah.
movement is not
Yeah.
super easy. I actually quite like that.
Yeah.
So
Yeah.
is he
Fine.
you're saying it's more
Kind of
like
Yeah,
the
just
lower?
more in and
Yeah.
out is-
Yeah.
is
And
kind of the
range.
way.
Well, because that's, I could point to my pain, that was my exact pain that builds up and everything goes sideways.
Okay.
Then I might double chin, take it out, and then it can, like a lot of them like start
Side
here.
bend.
Okay, so I was in.
Not as bad on this side.
I mean, I don't love
So
it.
Megan does
Yeah.
often tighten up on that right side.
So then you might go, is there a loading issue on that side? You know, we're not spring chickens anymore, there's like some joint changes.
Yeah.
If she then gets a whole load of muscular tone happening around there because of shoulder work or doing loads of shoulder pressing, has that just added more compression to a sensitive structure?
Yeah.
You go, right, I'm going to treat that.
Yeah.
I'm going to mobilise that. We'll talk about how we treat that
Yeah.
later on. And it's sort of different depending on provocation.
All right, do you want to do the cervical flexion rotation, and then I'll do.
Yeah, so
I have to do this in front to see the angle of your nose.
This is
I was
only
gonna
a
say,
screen, it's not a much better test of flexion rotation test.
Ah, right.
This is gonna be like stiff. That's fun.
Are we going here? Yeah.
So I'm going there and then.
so your upper cervical.
Yeah, so you should
Yeah,
feel when
fine.
you get to about 15
Yeah, that
degrees,
feels good.
Yeah, I just don't like that, which fits
Yeah.
in with
Doesn't
my
want to move
thing.
anymore.
Let me have a look at you.
Yeah.
you should
Get it?
Do you
feel
want to do my left?
I feel
So,
like
go
I'm
right.
Oh, okay. I felt like the opposite. It felt
Go
like it was
left.
stuck in the left.
and you can do it, you can stand,
Well, and I think it's
stand on
tighter
both
than it
sides.
was.
So you want to go, okay, if I block C2, like from there,
Yeah,
it
and then
wants
chin
to
down.
move under my thumb and I'm blocking here.
So if I
and then
have
I
it here,
would
while
probably
I'm
do the other
here.
side with the other
Okay.
hand.
Going
Yeah.
right and going left. Right, that's pretty good. So then if I add the
What about upper
upper cervical
And
side,
but you want to put into your
we
thumb.
get you.
Yeah, there.
Oh, okay.
Kind of
And that's
yeah,
why I was
yeah.
feeling to the left and not to the right.
I think it was
Okay.
actually, yeah.
It's a bad time to say I'm
So,
So
Does
you're-
it feel nice when we're doing
You're
this
going to
on
get
stage?
people that come in that are like rugby players with these
Yeah.
massive necks that you go, I can't feel anything. It's just
Yeah.
like a tree trunk. But that's okay. You're going to get other people that come in with, you know, nice tendon and go, well, this is amazing. I feel everything moves. So you just got to practice, and sort of just
And
sort of
then-
put it together. There's no definitive. If I do this, it's that. It's kind of like putting a picture together with something. Okay, so have a sit down. What I want you
we're definitely
to
on
have a
the
go at
left,
now
maybe
is
recommend
so
this
that
on the right.
rotation you're actually
think both
checking the
hands.
alar ligament as
Yeah.
well. So what I want you to feel
Yeah, that's
is
it,
where
that's it.
C2 is, you
Yeah,
can
that's
pinch it like
good.
that, and
Yeah.
if you side bend,
Yeah.
Yeah.
you'll feel
Okay.
the spinous
Wait a
process
minute.
moves
This
the
one.
opposite
So-
way.
Okay.
Come
That
on then.
is also an alar
And then
ligament
go
test.
with
So
Okay.
as I do that, C2 is going, there's the bony bit, it's moving away.
Moving really
And this is all
moving.
like your upper
Yeah,
cervical.
it's not
It's
so
just
bad on
interesting.
that
There
side.
we go.
What are you doing there?
So if you block C2 and do that rotation, then you're just getting that.
Yeah.
Yeah,
that
apparently
sort
I
of
can only
few-
block it with my thumb.
Like
apparently.
yeah, that
Really
few
basic.
degrees.
Yeah.
The other alar ligament testing, and you can do it in sitting or supine, is to find the spinous process of C2, sort of
Oh, like
pinch it or palpate it, and then
Yeah.
as
Yeah.
you side bend, it will contralaterally
Okay.
move.
So it moves.
So the,
That's it, yeah.
as I side bend Annie to the right, that spinous process will move
To
to
the left. Let's
And
do
the-
that.
yeah, and the same.
Where do you put your thumb?
I'll move to the left.
Normally.
Yeah, I was like on this side.
That's what you
Side.
want for-
Yeah, that shows that that alar ligament is
Interesting.
getting taut and pulling
Oh,
C2 in.
okay, yeah.
So wait a minute, so I do my little rotation, and that's that 13 degrees that it should have.
Yeah,
That's for transverse or alar?
alar. Alar is the rotation ligament. And then if you side bend,
Yeah.
you can do it on yourself. You know, you can palpate and you can side bend and you'll feel that.
Yeah.
Oh, yeah, it moves the other way.
Yeah. And you can, again, you can actually
That's
block that. Yes,
Yeah,
you just
I mean,
feel it
I
and then
just
side
get
bend, you
stretched
feel it
through
and
my
you
pecs.
side to side. So that shows you've got an intact alar ligament.
Okay, and if you didn't, if
It
it was,
wouldn't, no. It
You
might
just
not,
get
it
that.
may
Yeah,
not.
my
know.
optics
And
is
again,
really
remember the specificity and sensitivity of these tests is not 100%. You could also check it by completely blocking C2, don't let it move, and you should get like a much sort of stiffer, rigid movement because you're not allowing it to pull C2 with it.
okay,
That's more of a alar ligament test. Yeah?
yeah.
So that's feeling the upper cervical spine move, and we'll do something else for C1, 2 in a minute. So we've done C1, C01, and we've put a bit of provocation on that as well. We've done C2 where we block, C1, 2 where we block C2 and we've turned the head, and that's also an alar ligament test, and then we've looked at that other alar ligament test. The other ligament testing is the person that goes, yeah, when I look down, I get pins and needles in my feet and hands, and you go, okay, is that a transverse ligament issue where, you know, that's gone, and so when they go forward, the dens is hitting the spinal cord. So you would do the Sharp's Purser test, which is actually a relocation. So you would find C2, and you would block that, and you would try and translate the occiput back. And if they went, yeah, that's much better, and you might hear a clunk, you'd go, okay, that's a positive test.
And do you do this like while they're flexing, or is it just?
No, you do it in that position.
Okay.
Yeah. You might then go, all right, okay, well, they got sensations when they bent forward, so if I do that as they bend forward, does that reduce it?
Yeah.
Yeah. If that was positive and you did get a clunk, you wouldn't do the next bit, which is the anterior shear, which is where you hold C2 and you pull the occiput forward to try and reproduce their symptoms. So there's this thinking.
It's almost you're trying to provoke.
You're trying to provoke it. Oh, there's this thinking. Would you do that if you suspect it, or would you just go, I suspect that, we should get you seen? I don't know. Jury's out. I'm just showing you that this is how you test it. So have a go with that. The last one is the tectoral membrane. So what you would do is you would grab.
You rip the head off, don't you?
Yeah, you grab C2 and you try and put some caudate force down through there, and then you grab the occiput and you're trying to pull it up and away, like trying to pull the head off. And then you should get like 1 or 2 millimeters movement. You go, oh. So that's.
They have a lot of movement.
Yeah. The reality is I don't test these very much, but it's good to know what it is you're testing and why you're testing it.
So wait a minute, what am I doing?
Transverse ligament, so it's that Sharp's Purser, which is a posterior movement of the occiput on C2.
So we're here, I hold that, and go to start, feel better.
Yep.
And get a clunk, or
Hopefully not. Or
And then, what was the other one we were doing? Oh my god, my brain. Yeah, Tectoral membrane, it's like,
apply the full.
I'm probably doing my wrong hand squashing your head. Hey?
The forwards one.
It's just kind of, it's like a sloppy, I think of it as, is that upper cervical
It feels
spine
like I'm
sloppy?
more doing like.
Yeah.
I couldn't tell you what it was, but is it sloppy or is it not bad?
Yeah.
You want to go on me?
Side on, yeah.
This is what happens with
I suppose it's not really going to feel like
when you've lost that transverse ligament.
as well with the right spots on there. Okay, this is.
What's
So
is that a spine?
that's C1,
The
2. C1, C2.
Oh.
Yeah.
So the transverse ligament will prevent that.
Oh.
Did you see that?
Yeah, so I don't know if I'd be wanting to do
Can't
that on
see
my
that.
face.
It's just to know that's what the ligament does.
Oh.
Um,
Kind of spooky. Ugh.
So what am I doing here?
So you
so
can
they'll feel
traction
the
it.
symptoms as they move
So
forward.
traction, hold C2, it's like, hold C2, move it back, forward, up and down.
That were in the goalpost.
Okay.
They discovered that she had something like that going on.
Well, no, you want to
And
relocate.
then she wasn't allowed to just
That, does that feel better?
I did this before, didn't I?
So that's Ayla, is
Yeah, so
rotation.
now what you're trying to do, Sharp's Purser, is you're
Yeah.
blocking C2 with your index finger and you're translating the occiput
Okay, so
back.
yeah.
And if that goes, that feels better, or there's a clunk, that's a positive test.
Yeah,
I feel
definitely
like I'm
relocating that,
comfortable your
and
head
now
between my
do
feet and
traction.
my arm.
Alright,
Yeah.
let's go.
You know, and
I
you,
just stand up to
Tectoral
close
membrane.
you might do that, then you have to figure out,
That's it.
Just get her in there.
you have to figure out
It's kind of like, I just think of it as
pillow
sloppiness.
technique.
Yeah.
Essentially,
Just
you're-
put a towel over your
Yeah.
head.
it's almost like you're
All
doing
feels quite good,
an
really.
I know.
PA of C2, and so you're just blocking C2 as you translate back.
And what about, are your hands in the same position as your leg?
So
And then they are, but I'll
just
come more
into
there to put
sun.
pressure
Came
down.
off his motorbike down
Hold
his
that and then
friends,
try
Sarah
and
holidays,
distract it.
and his girlfriend came off,
With the other one,
and she drove into
the
hospital.
compression one,
She's lost the
Berlin.
how
She
far
flew,
are we taking
Or across the back
someone
of the
like
city.
Emily
And when you got your
just-
so it turns out
and then I'm
that's
still
more of
compressing
a
from
trauma.
it.
Yeah, so someone like her
C2
that
fracture.
hasn't got signs of cervical predictable
Yeah.
referral
No.
pain and is super mobile,
It's just
I'd
like,
probably be a bit
there's
cautious
so
about
many
those,
traumatic
Yeah.
things happening to them.
I don't feel
You
very
just got to know
confident
where
in
to
just
do it.
taking you down.
Yeah, I reckon if I was to try and get my head out of
Then
that
come and lie down on your back.
Yeah, but because you've got it like mine.
So I want to rattle through a couple of things here. One is C1-2 flexion rotation test. So we've kind of hinted at it in sitting, but this is kind of like the best test that we've got for C1-2. So if you've got to get someone right up towards the end of the bed.
I just spotted that right, it looks like it's going to fall down. Patience here.
Okay, thanks.
Okay. So you're going to bring them up into full range cervical flexion and you're going to rest them on your stomach. And the first thing you're going to say, is that okay? Because sometimes they don't like really strong stretch. Most people will handle that surprisingly well. And then what you're thinking is that you've got this axis down through the centre of the head. So you're maintaining that upper cervical flexion, thumbs on the mandible, and then I'm looking at Megan's nose as my indicator, and I'm going to provide pure rotation, and I'm looking for that sort of 40 degrees-ish each side.
We should get a close up of that.
Now,
On the Instagram.
if someone goes, yeah, and they've got 40, 45, and you come this way and they've got like that, that's a C1-2 dysfunction in the left rotation.
Yeah.
Yeah.
So it's very like that test, but much more specific.
Very
Because
specific.
You're locking off everything
Much more
else.
specific,
Yeah,
but
it
it's
is,
done well.
you can feel it.
Yeah. The other thing that you can, time-wise, you've got 2
So
minutes.
just show me, we're recording it, we can go
Are
over it.
you?
Yeah.
So I would probably have a feel of the neural tissue. So I would feel down through the neural tissue in both arms, and then we might do motion palpation of the rest of the neck next time. So find the clavicle, come along here, you'll find that subclavian pulse. Should have one there. Just lateral to that is going to be T1. C8, I should say, in there. And it's a bit sensitive. And then as you come back up, you'll feel, okay, now I've got C7. You come up. C6. Down to C5. So I would probably have a feel of those structures. C6 on the left has a little tubercle that you can kind of sort of palpate over and feel. This is all a bit sensitive at the front of the neck. Generally, where SCM starts to expose a bit of the neck, that's probably going to be around C5. So I would feel that. If they've got pain coming out into the shoulder, I'll generally feel in behind the AC joint, that's the suprascapular nerve. If they're tender in there, I'll have a bit of a dig in there. I'll come in behind the deltoid, so that radial nerve in the spiral groove. Have a feel and compare it. It's sensitive. Compare it both sides. You've got the posterior interosseous nerve, which is just sort of behind brachioradialis and between extensor carpi radialis brevis, and sort of have a feel in there. We all know where the ulnar nerve is, just behind here. You can go above the elbow, up here, feel it and flick over it, it's like a little rubber band, or you can come below the elbow, you can feel that there as well. We've got the median nerve up here, which sits sort of superior to the humerus, you can sort of roll over. So you can feel down through the arm if they're getting neck and arm pain.
So again, you're trying to prove that the nerve is somehow,
Sensitized compared to the other side.
yeah, okay.
and if the neck pain has a has a neural tissue type of sensitivity to it. I'll do one last thing, and then I think we should probably wrap it up. Is there neck pain neural in some way, shape or form? Does that bring on your pain? Not really. Okay, take your arms out into a crucifix position. Does that bring on your pain? Sort of loading it up? Not really. You can bring the feet up if you really want to do it, or you can get them in long sitting and take their arms down and take their arms out. Does that bring on your pain? And if it does, you go, well, then maybe some neural tissue involved. Yeah, so if you sit up in long sitting,
Where you would just go, oh
So
yeah,
if I go-
stand your arms neural.
like this, oh yeah, it's bringing on my neck pain. And then you can bring your arms out. Oh yeah, that's bringing on my neck pain. It's fairly rare, I would say. But,
So when you say that, is it meaning that the nerve is somehow trapped or
Sensitised.
Yeah.
just sensitised?
sensitized. Yeah, there's involvement there, as opposed to it just being a joint restriction.
Okay.
Yeah. So next time we'll go through motion palpation and treatment and some manual therapy and exercises to treat.
Sounds great. Thank you so much.
Pleasure.
Well, that fits in nicely because we're finishing off